Health disparities are the differences that we see in healthcare and health outcomes from one population to another.
There were two things that caused me to think about incorporating race-related disparity issues, the pharmacist's role in those issues, into my kidney fluid and electrolyte class. The first one, the impetus was really our own pharmacy students. We had grassroots efforts here in the College of Pharmacy by some students to point out that, we are using race-based algorithms for medical decision-making that weren't appropriate. And they also pointed out that, we weren't dealing with or handling race-related issues in our cases in the best way.
DEI stands for diversity, equity, and inclusion. It's something that I think has become a buzzword, but it's something that needs to be formally introduced to curriculum because it is something that's important. It impacts your ability to provide for a patient, it impacts how you view a patient's life, and it definitely impacts their life. So how we analyze that and how we integrate that into how we give medicine is hugely important.
And the second thing was my experience as a task force member on the National Kidney Foundation American Society of Nephrology Task Force on examining race in the assessment of kidney function. My time on that committee went along with some open forums that we had with patients themselves that really opened my eyes in terms of what we needed to do as pharmacists to help resolve disparities.
I think the conversations we had in class really opened my eyes to how to approach these situations, not just when I'm a practicing pharmacist in a few years, but even in my APPE rotations where I will be dealing with real patients.
One big takeaway that I got from class was that race isn't a biological construct, but it's a social construct. So I have worked with a provider, and this particular patient came in with really, really high blood pressure, and the provider kept insisting we have to do a specific class of medication because they're African American. And that's going back to race is not a biological construct, it's a social construct. We as, not as just a pharmacy student, but educating, the medical students, the nursing students, the dietitian, everyone, that this concept is extremely important and that we don't want to continue to have providers with this type of mindset.
The particular equations we were using systematically overestimated kidney function in patients who were African American compared to those that were non-African American. That means disparities in terms of these patients not being diagnosed with CKD early enough, disparities in not being referred to a specialty nephrologist or kidney doctor early enough, and importantly, not being able to be on the transplant wait list for a kidney transplant. We got some pharmacists together that have nephrology expertise throughout the country. We had experts come in to talk to us about these new value-based payment models. And at the end, we concluded that this was an opportunity to get pharmacists in the care loop of these patients to improve patients' outcomes. And so we formed this initiative called Advancing Kidney Health for Optimal Medication Management. The mission of this initiative is that every patient with kidney disease receives optimal medication management to make sure their medications are safe, effective, and can be taken by patients as intended. It's been gratifying to know that, something that we have identified as a gap, that we're now moving forward with this initiative to fill those gaps that are real gaps. And we're making such good progress with all the stakeholders that we've involved. So stay tuned.
Social determinants are the contexts in which people live their lives, where they live, where they grow up, where they school, where they play, where they work, where they worship, the context of their lives that then determine their health status and, of course, their health outcomes.
As a student going through pharmacy school, at least from a student point of view, we're always focused on like getting a good grade, like sticking to the rules and the regulations that are provided to us. As a pharmacist, obviously the medications are a big role to play, but we are never looking beyond the patient. Like, is that tier 1 drug even affordable for my patient? Are they able to actually use it?
In public health, we have this saying that your zip code matters more than your genetic code, which means where you live will determine a lot. You can have 2 people in 2 different zip codes that are just adjacent to each other, and life expectancy in one zip code might be 10 years more than or less than people in the other zip code. And I do an elective where I ask them to go and just experience the community. For instance, if you go and run in a different neighborhood, if you're a runner, it's different. Maybe you live in a nice neighborhood where you have this large sidewalks and, everywhere is like green spaces and all of that. Go try running somewhere else where, the houses are next to each other, the sidewalks are broken. You can't even get your physical exercise from living in this space.
Maybe the patient has transportation issues. It's hard for them to get to the clinic, to go to their appointment. Then they get prescribed a medication. Then they have to find a bus route to go to the pharmacy, to wait there and then go home. That's a long process. And a lot of patients, if they're working 12 or 16 hours a day, it's really difficult for them.
It made me aware of biases I didn't even know I had. Just reading through a patient case, I'd automatically picture somebody that would look like me. And then when we get into the disparities and realizing if you treat the person like you would treat looking like yourself, it'd be totally different than somebody that doesn't have the same background as you.
So it's important that we begin to orient the students. Now we're sure they're going to be competent clinically, but are they going to be able to see what the issues are?
It's perspectives I haven't thought about before because I've never had to. I grew up in northern Minnesota in a rural town, and there's not very much diversity. So coming to college was my first experience to anybody pretty much different than myself.
I don't want to present the same graphs that I present in class now that show this difference in prevalence, in access, in outcomes, I'm hoping that in 50 years that the gap has closed. So the goal is health equity. That's why we do this work.